Hello, everyone. Good morning, good afternoon, good evening, whatever time you have chosen to listen to me. I want to welcome you to this lesson. My name is Violet Aswa Akek. I'm a lecturer of pediatrics in the Department of Clinical Medicine at the Kenya Medical Training College. This lesson is primarily designed for clinical medicine students, but you're welcome to listen to it as part of your regular learning, or you can also listen to it as part of your revision program. Please feel free to subscribe and also check the notification bell so that any other time we post a video that may be of interest to you, then you may be able to know in good time. So welcome. Today's lesson is going to be on immunizations, and I'm going to be introducing the entire topic. There are some reviews that we shall do that relates to content that has already been covered in first year or in other sections of training, other modules like the community health. So in this first session of our topic on immunizations and immunizable diseases, we are going to be reviewing the general defense mechanisms, the types of immunity, and the vaccine types. We shall also be looking at the effects of maternal antibodies and how they affect the timing of immunization or administration of vaccines in the infant or the child. Thereafter, we shall look at the global and local immunization agenda. So this is what we shall be covering in this session, and the other sessions shall come in the next succeeding sessions. So let us begin by looking at the general defense mechanisms. Here we are talking about other ways that have nothing to do with the specific immunity. They have nothing to do with the activity of the white blood cells, which is the non-specific immunity, but these are just general defense mechanisms that the body puts forth whenever there is an infection or a noxious element that has gained access or entry into the body. Say, for example, when an individual has eaten food that is perhaps infected or contaminated, naturally, the body will respond by enabling this particular individual to vomit. The act of vomiting is a general defense mechanism. It helps to remove the noxious elements. It helps to remove the toxins. And so is diarrhea. In your work of pediatrics learning, you are going to realize, if you haven't already, that we rarely and hardly recommend the use of antiemetics or antidiarrheal agents in children, because we are more concerned about what is causing the diarrhea or the vomiting. And so when that cause or etiologic agent is dealt with or controlled, then the diarrhea and vomiting is stopped. So we usually do not advocate for giving antiemetics or antidiarrheal agents, that is to stop the vomiting or stopping diarrhea in children. Cough is also another general defense mechanism. Let's say, for example, an individual has inhaled a chemical agent. The natural way the body will try to protect itself will be by coughing that particular matter out. So cough is one other general defense mechanism. It is non-specific. It occurs anytime there is a noxious element that has gained entry into the body, and also helps to eliminate it. Another general defense mechanism is by way of inflammation. And again, inflammation is extensively covered in first year under the topic inflammation or acute inflammation. We all know that during the process of an acute inflammation, there will be formation of the inflammatory exudate, forming the edema. So, during that time, one of the benefits of the inflammatory exudate or edema is to help dilute the toxin, is to help dilute the offending agent. Another way is also, one way that dilutes the toxins is by way of increasing the intestinal flow and causation of diarrhea. And then we have the phagocytic activity of the white blood cells, the macrophages, and so on and so forth. These again are non-specific, and they will be there to remove any dead bacteria, initially to phagocytose the bacteria and remove them, also remove the dead cells and other tissue debris that may be at the site of injury. So these are some of the general defense mechanisms. They are not all. We also have the skin as a mechanical barrier. We have the normal flora in various parts of the body which also act as general defense mechanisms. Let us now take a look at the types of specific immunity, and this is just an overview. So specific immunity can either be active or passive. When we say that immunity is active, we mean that an individual is able to produce antibodies by themselves. That is an active process. The body produces antibodies against a pathogenic organism. How does this happen? It can either follow infection with that particular microorganism or vaccination for a particular infectious disease. In both cases, the individual is triggered, or the immune response is triggered to produce antibodies actively, and thus the term active immunity. Specific immunity can also be passive. In this case, an individual will receive antibodies, ready-made antibodies. That means they do not have to produce those antibodies, but they are specific. That means that the specific antibody for a particular disease or infection is injected into the body. Examples are when a patient, for example, is infected with the tetanus bacteria, and they're now suffering from tetanus. One of the most important things that we do during management is to inject them with an antiserum. The antiserum contains antibodies against the tetanus toxoid. In this case, the individual will benefit from the anti-tetanus toxoid, but they'll not have produced the antibodies themselves. The other way is by passage of ready-made antibodies from the mother to a breastfeeding baby or to the unborn fetus in utero via the placenta. So these are the two main ways an individual can benefit from passive immunity. So specific immunity can either be classified as active or passive. Active following active production of antibodies following either infection of the disease with the disease or receiving a vaccine. Passive, an individual receives or gets ready-made antibodies against a particular infection or the antibodies are passed from mother to baby or mother to the unborn fetus. We are saying that no particular immunity or type of immunity can fit a particular or single definition. Immunity can either be specific and passive at the same time. It can be non-specific and natural. So there is no one immunity that can fit just one type of classification. So it is cross. Now, when we are talking about the act of immunization, there are two things that need to be remembered. One, that to vaccinate is not the same as to immunize. To vaccinate is just to introduce the vaccine into the body. But whether or not an individual will be immunized is different. It depends on how successful an individual will be able to mount an immune response once the vaccine has been introduced into the body. So remember the difference. The act of immunization, an individual being said to be immunized, means that besides receiving the vaccine, the individual went on to mount an immune response and they were able to produce antibodies. So we are saying that during the act of immunization, a relatively harmless variant or metabolic product of a pathogenic organism is introduced into the body. And this is what we call a vaccine. So a vaccine also, you can say that it is a vaccine is something that contains either a variant or a metabolic product of a pathogenic organism, which is then introduced into the body by way of vaccination. And it is expected that this particular vaccine will be able to cause the individual to mount an immune response and be able to produce antibodies. So, when a vaccine is introduced into the body and an individual is actively immunized, it therefore means that they are able to produce specific antibodies against the microorganism whose variant was introduced or whose metabolic product was introduced into the body. This is specific immunity, and it is active in nature. Why do we say it is active in nature? Because the individual is able to produce antibodies by themselves. So another thing that we need to look at and remember is, why do we give sometimes more than one dose of a particular vaccine? And remember, all these practices are based on findings that have been carried out during research projects when the vaccine is being produced. Some vaccines are able to give an adequate immune response that is able to protect an individual for a good duration of time, and therefore these vaccines only need to be administered once. However, there are other vaccines whose potential to make the body produce or mount a reasonable immune response may not be adequate when it is just given as a single dose, and therefore you find that it is necessary to give more than one dose. So the rationale for giving more than one dose is banked on the presence of memory cells. Remember, anytime there is an immune response and there's production of antibodies, there are various classes of antibodies or types. We have the IgG, IgM, IgA, and so on and so forth. So IgG is the one which really is the most abundant or is found in highest amounts in circulation anytime there is an immune response. However, we also have another type of immunoglobulin that is called IgM. IgM is usually the first one to be produced, and as the letter suggests, M for memory, it is the one that retains the memory for that particular pathogenic organism. That means that the memory cells are there to remember this particular organism that has led to the activation of the immune system. It means that Any other time an individual comes across or is exposed to a similar antigenic material that this individual has been exposed to before, the memory cells will quickly remember that particular pathogenic organism, and therefore the corresponding response will be much faster and much stronger as compared to the first exposure. So the first administration of a vaccine will usually lead to production of memory cells, that is the IgM. It is this IgM that will usually lead to a much faster response and also a stronger response on subsequent exposures to the next exposures to the particular microorganism or pathogenic organism. And that is the rationale why sometimes we have to give more than one dose of a vaccine, just that to make sure that we have a good immunity in case this individual then gets exposed to the organism in real life. Having said that, let us just look at the types of vaccines. This again is extensively covered in community health, but we shall just look at it for purposes of revision and setting the ground for our lesson. How do we define a vaccine, therefore? A vaccine is a substance that is used to stimulate immunity to a particular infectious disease or pathogen. This is usually prepared from an inactivated or weakened form of the causative agent or its constituents or products. So, a vaccine will usually contain the real organism but in an inactivated form or in a weakened form, especially when you're making reference to the live vaccines. They are the real organism that causes the disease. However, it is inactivated or weakened. So much so that it is able to cause an immune response, but it should not be able to cause disease in an otherwise healthy individual. Besides that, a vaccine can contain either one of the constituents or the elements of a pathogenic organism or one of its products. So here we are talking of endotoxins, for example, and also exotoxins. And a very good example of those products would be toxins as would be produced by an organism like the Clostridium tetani. So in that case, the vaccine that will be produced will be of the toxin, also known as a toxoid. So there are many types. We are saying it can be killed or inactivated. In this case, it is the real microorganism, but then it is either inactivated or killed to some extent. Live attenuated. This one carries real properties of the microorganism or the pathogenic organism, and if the individual is immune compromised, then these kinds of vaccine can actually end up causing a real clinical disease. Remember, a vaccine is supposed to cause the body to mount an immune response, but it should not be able to cause the real clinical disease. However, we are saying that this administration should be very cautious, especially if you're dealing with an individual whose immunity is compromised. Other vaccines could just be containing messenger RNAs, and that is for viruses. Some will constitute of a subunit of the microorganism or a recombinant or polysaccharide or a conjugate. Those vaccines that contain a portion or a unit of a microorganism and are referred to as either subunit, recombinant, polysaccharide, or conjugate vaccines. Then we have toxoids. Toxoids are the ones which will be containing a toxin that would be produced by a particular microorganism. And we have given the example of the tetanus toxoid. And then we also have other vaccines that will contain viral vectors. Okay. So We will make reference to our national immunization schedule and see which of those vaccines fall in which category of vaccine type. So, of the live vaccines, we have the BCG, we have the measles vaccine, we have the hepatitis B vaccine, rotavirus vaccine, the MMR, that is measles, mumps, and rubella, and then we have the yellow fever vaccine and the oral polio vaccines. These vaccines contain live organisms. They should not be given or administered to patients or individuals whose immunity is compromised. Just to note that the oral polio vaccine will usually contain the 3 poliovirus types, and so it is given 3 times so that all the 3 poliovirus types have an equal chance to at least give an adequate immune response from the individual. And then we have the killed or inactivated vaccines. These are the dead microorganisms. An example from our national immunization schedule would be the pertussis vaccine and the inactivated polio vaccine. Toxoids. These ones are with reference to the tetanus vaccine or tetanus toxoid and diphtheria. Those two are toxoids. And when you look at the pathogenesis as caused by these two particular organisms, the Clostridium tetani and the diphtheria, you'll find that the organism themselves do not cause an infection. Rather, it is the toxins that they produce which end up to cause disease. Then we have the recombinant or the conjugate vaccines. In this category, we have the Haemophilus influenza type B, we have the pneumococcal vaccine, and then malaria vaccine and the human papillomavirus vaccines. So these are the types of vaccines that we find as represented in our national immunization schedule in Kenya. Now, let's look at the effects of the maternal antibodies. We know that a mother will usually pass antibodies to their child, either unborn baby or during breastfeeding. And if the antibodies for that particular organism are able to cross the placental barrier, then it really affects the timing of the vaccination depending on how long the maternal antibodies will usually be resident in the newborn baby or in the infant. So we are saying that the maternal antibodies will usually affect the timing of vaccination. So vaccines cannot be given when the maternal antibodies are still in circulation in the baby or in the infant. The reason is this. If the maternal antibodies, let's take an example of measles. If the measles vaccine is given or administered when the maternal antibodies against measles are still in circulation, it means that the measles vaccine will meet or encounter the maternal antibodies in the circulation of the baby, and they will be neutralized. So the vaccine will be neutralized by the maternal antibodies in the infant, and so it will not have an opportunity to cause the body to respond. And therefore, we must wait for the maternal antibodies to disappear, to wane off completely, before we can give the vaccine, so that the vaccine material can be able to cause the body to mount an immune response and therefore to produce antibodies. So that is the reason and the explanation on how maternal antibodies will usually affect the timing of vaccine administration. But then it really depends on how long do these maternal antibodies stay on in the circulation of the baby or the infant, and also whether or not the antibodies for that particular infection are able to cross the placenta barrier. So we are saying that antibodies against tuberculosis do not usually cross the placental barrier. In this case, even if the mother has suffered tuberculosis, It means they have produced antibodies against that, or the T lymphocytes have been activated. These do not cross the placenta barrier, and so the baby can receive the vaccine soon after birth because there is no risk of having antibodies in their circulation that would neutralize the vaccine. And that is why BCG can comfortably and safely be administered at birth. Antibodies against the polio viruses, against the diphtheria bacteria and pertussis, that is the whooping cough, and tetanus, all cross the placental barrier. That means they are able to go to the fetus and born baby if the mother has suffered these infections and therefore has produced antibodies, either suffered or been vaccinated. However, the antibodies for these infectious pathogens that we have mentioned do not last in the body of the born baby for a long time. Some just last for about a month. That means shortly after a month, we can easily or comfortably begin the vaccination for polio, pertussis, tetanus, and diphtheria because they do not last so long in the baby's circulation. Tetanus immunization, as you will have learned in reproductive health, is given to all mothers who are expectant so that they can be able to produce antibodies. And remember, we said that antibodies against tetanus are able to cross the placenta barrier into the unborn fetus. So, all pregnant mothers are usually immunized with the tetanus toxoid vaccine so that they can be able to pass immunity passively to the unborn baby and therefore protect the newborn from neonatal tetanus, which in our setting is still an important disease. The reason it is given to all pregnant mothers is because the mother may not have suffered or been immunized with the TT or tetanus toxoid recently. However, you would usually want to take history and find out when last did this mother receive tetanus toxoid in life. Or also, remember we have the schedule for tetanus immunization for all women of reproductive age. If a mother has gone through all the algorithm for TT immunization and they have reached a point where they are protected for life, then you may not have to give the tetanus toxoid if they are pregnant. But if they haven't, which is usually the scenario most of the time, then you'd have to give. Therefore, I'm saying that you must take history and know and then make a decision. But all pregnant mothers, we want them to be able to pass the tetanus antibodies to their unborn babies in order to protect the newborn from neonatal tetanus. Very important. Measles. The antibodies against the measles virus also cross the placenta barrier, and these antibodies happen to be the ones that last the longest in the infant's circulation. The duration is usually from 6 to 9 months. So a baby born and the mother has suffered measles before, and remember, suffering and recovering from measles infection usually confers an individual with lifelong immunity. That means that these antibodies are in circulation so long as the mother has suffered measles when they were young or at some point in their life. The measles antibodies begin to wane off from the age of 6 months up to about 9 months. Therefore, some babies are able to get measles from the age of 6 months. That means, as we shall look at the schedule, our national immunization schedule, you will see when can you begin to give the measles vaccine at 6 months, and then when can you wait up to 9 months. So we shall see about that. Having looked at how maternal antibodies usually affect the timing of immunization in the infants, let us now look at the global immunization agenda. Its vision is to have a world where everybody, irrespective of where they are, irrespective of their age, that everyone must be able to benefit from vaccines in order to maintain good health and well-being. This is the vision of the Immunization Agenda 2030. Irrespective of where an individual is, the age they're at, they should be able to benefit from the vaccines that are available in order to make sure that they are in good health and their well-being is maintained. The impact of the immunization agenda is threefold. Number one is to reduce mortality and morbidity from vaccine-preventable diseases. Please note, vaccine-preventable diseases. That any disease that can be prevented via a vaccine really should not cause people to die, should not cause people to be sick. Why? Because it is preventable and the vaccine is available. And remember, the vision is to have everyone, everywhere, benefiting from the effects of vaccines. So, the impact going forward is to reduce the morbidity and mortality as would be caused by vaccine-preventable diseases throughout the world and in the course of life. The second impact is to leave no one behind. That means everybody must be included. Leaving no one behind, how do we achieve that? By increasing equitable access and use of new and existing vaccines. That means everybody, every child must have equal opportunity, equal chance of accessing high quality vaccines without discrimination. The third impact is to ensure good health and well-being for everyone by strengthening immunization within the primary health care facilities and also contributing to the universal health coverage and sustainable development. What this huge statement just means is when everybody receives or benefits from the good effects, the positive effects of vaccines, going forward, we shall have a reduction in the mortality and morbidity of diseases that can be prevented via vaccines. We shall have nobody being left behind because we are making reference to everybody. And then the good health and well-being of all citizens shall be ensured. Threefold impact goals. Having looked at the global agenda, let us now come to our region, which is Kenya. Now in Kenya, we had the Kenya Expanded Program of Immunization. K standing for Kenya, EPI standing for the Expanded Program of Immunization. Now, KEPI was launched in Kenya in 1980, and this was as part of the WHO or World Health Organization Expanded Program of Immunization that had been launched in 1974. Now, in Kenya, the aim was to immunize all children from age 0 to 5, and this immunization was supposed to be free of charge. And then later, this age was revised downwards to 11 months. So initially, it was to immunize all Kenyan children free of charge who are less than 5 years and pregnant mothers so as to reduce the morbidity and mortality and also the disability from the then 6 common childhood infections. Those infections were tuberculosis, poliomyelitis, diphtheria, whooping cough, tetanus, and measles. And like I said, initially it was 0 to 5 years. Later, the upper age limit was revised downwards to 11 months, meaning that all children should have received full immunization against the then six commonest childhood illnesses by the time they were celebrating their first birthday. Later on, right now we have the National Vaccine and Immunization Program. So where did this one get born from? Remember, in 1980, Kenya launched the KEPI program, which was addressing the then 6 top infectious diseases that were affecting children. Later on, in the year 2008, KEPI was renamed as the Division of Vaccines and Immunizations, which was abbreviated as DVI. And currently, it has been rebranded as the National Vaccine and Immunization Program. Therefore, we do not expect you to be making reference to KEPI at this time or the Division for Vaccines and Immunization. Right now, that has been rebranded and it is now referred to as the National Vaccine and Immunization Program, NVIP. At the moment, it is providing 14 vaccines. This is the portfolio. Number 1, we have the childhood vaccines, including those that are offered during infancy through to adolescence. Number 2, we have the tetanus and diphtheria combination for pregnant women and individuals who have had penetrating wounds or traumatic injuries. Then we have various COVID-19 vaccines. Then we have vaccines for special groups. And which are the special groups? We have the occupational individuals who are exposed to specific occupational risks. And this becomes your assignment. I need you to go and find out which are some of the occupational risks for which health workers and other veterinary workers can be vaccinated against for their protection because of the nature of what they do. We also have vaccines for food handlers, for example, the typhoid vaccine. And we also have vaccines for travelers, like the yellow fever vaccine. These are vaccines for special groups. And then there are also other vaccine products, like the anti-rabies, that is for individuals who have had dog bites from animals that may have otherwise been infected with rabies. Anti-snake venoms for individuals who may suffer snake bites. And then we have immunoglobulins for hepatitis B. This is very useful in children or newborns who have been exposed to hepatitis B. That means their mothers are actively suffering from hepatitis B. We also have the immunoglobulins against the anti-D, against the rhesus factor. That is for mothers who are rhesus negative and their babies or their infants are rhesus positive. So all these are vaccines that are within the National Immunization and Vaccines Program. Then we also have vaccines that are specific to outbreaks. These are vaccines that are released in response to specific outbreaks. For example, if we have an outbreak of poliomyelitis, then they will be released. Measles, meningitis, and etc., etc. So those ones are also available. And also any other vaccine and specialized products that may be deemed essential for any section of the Kenyan population. So the National Vaccines and Immunizations Program takes care of all this entire portfolio. So, what is the vision and mission of the NVIP? The vision is to have a Kenya that is free of vaccine preventable diseases. And this is in line with the immunization agenda of 2030. What is the mission? It is to save lives and protect people from vaccine preventable diseases by promoting and guiding the provision of efficient, equitable, safe, and effective high-quality immunization services to all Kenyans. That means Kenya is not just in the business, or the NVIP is not just in the business of making vaccines available, but it goes on to make sure that the vaccines being made available to Kenyans are efficient, they are potent, that the availability is equitable, that nobody is left out, the distribution is equitable, that these vaccines are safe, they're not dangerous, they don't carry unnecessary adverse effects, and that these vaccines are of high quality and available to everybody. Okay. So this is what you're saying. Remember that the coverage is very important. When the coverage is high, the percent coverage is high, then we also improve on our herd immunity. Okay. We also need to reduce the zero-dose children, and we shall see who are the zero-dose children, what is the definition of that statement. And then the vaccines must be available in a manner that is not interrupted, so that children are not coming for vaccines and then they find that the vaccines are not available. That situation should not be arising, and that becomes a goal of the National Vaccines and Immunizations Program. So what do we mean by zero-dose children? In our setting, zero-dose children are those children who have not received any vaccine in the EPI schedule, and they are usually captured in the records as children who are eligible but have not received the first dose of diphtheria, tetanus, pertussis containing vaccine. That is the pentavalent one. It means maybe these children were born at home or even in hospital. And if they were born in hospital, then perhaps they received the zero doses, the birth dose vaccines, that is the polio and maybe the BCG. But then they never received any other vaccine, yet they are eligible and they are of age. These are the ones who are referred to as the zero-dose vaccine. And in the goal is to reduce the number of the zero-dose children. So our main reference materials have been the Muya's textbook of pathology and also the Kenya National Immunization Policy Guidelines of 2023. That brings us to the end of this session 1 on immunizations. I want to say thank you for your indulgence. Thank you for your time. I look forward to hearing your comments and your questions when we meet physically in class on campus, and we shall be happy to discuss them. So thank you and have a lovely day, have a lovely afternoon, or have a lovely evening, whatever time it is for you. Bye.